Thank you, Sylvia, for this kind introduction. So this session is sponsored by Sanofi, and these are my disclosures. Large data sets, such as the one from Denmark by Mulder, allowed us to understand more about the nature of cancer-associated thrombosis. As you can see, over 20 years, 12 months cumulative incidence of VTE in cancer patients increased threefolds, and it's now ninefolds compared to the non-cancer patients. And on the right side, you can see actually that tumors of the pancreas, hepatobiliary, ovary, upper GI, and non-small cell lung cell, as well as hematological malignancies such as myeloma and lymphoma, are at a very high risk, and the risk increased over the years. And this leads to the question, how do we prophylax this problem? The reason for this increase is partly due to increase in our evaluation studies of cancer patients, but also due to the treatments that we give to cancer patients. Before it was only chemotherapy, but now PKI, immunotherapies, all increase the risk of thrombosis. Maybe we can learn more on disease-specific risk when we studied, for example, in certain tumors such as lung cancer with the COMPASS CAT score, or with lymphoma with the Trolley score, as well as with myeloma with the IMPED score and the SAFE score about the disease itself, because the Corona score, which has been around for 13 years now, is very simple, but is sometimes has limitations in certain tumors. But if we do take the Corona score equal and above 2, and we look at the studies, there are 4 low molecular weight heparin studies, dalteparin, enoxaparin, bemiparin, and semoloparin, and 2 DOAC studies, rivaroxaban and apixaban. We see that there is a significant reduction in the risk of thrombosis, 50% reduction, and the number needed to treat is relatively small, only 25. And the price to pay is very low, as you can see here, no increase in major bleeding, and the number needed to harm is very high. So the guidelines for prevention of VT in ambulatory cancer patients receiving systemic therapy, you see the ASH and the ASCO guidelines here, is actually, if there's patients with intermediate or high risk, then there is, of course, you have to give thromboprophylaxis with either a DOAC or low molecular weight heparin. There are special indications regarding multiple myeloma treated with IMiDs, and of course, thromboprophylaxis with low molecular weight heparin is recommended in high-risk patients. Now, going to the patients with cancer who already developed venous thromboembolic events, what should we do? And here we have 4 studies in this slide, and actually now with the Castadiva study with 5 slides of DOACs, edoxaban, rivaroxaban, and apixaban compared to dalteparin, which was the drug of choice before. And as you can see, there is a decrease in the risk of recurrent VTE, or actually getting into almost significance. But there is a price to pay. There is a 35% in the increased risk of bleeding, not statistically significant, and 83% increase, significant increase in the risk of clinically relevant non-major bleeding with a DOAC compared to low molecular weight heparin. And this brings us to the guidelines of treatment of VT in patients with cancer, the ASCO, the ASH, and more recently, the ACCP guidelines. And the evolution of these guidelines, according to the years, it's according to the publication of the studies with the DOACs. And if we go to the last ACCP guidelines here, you see that VT treatment phase in active cancer, DOACs, apixaban, edoxaban, or rivaroxaban are preferred on low molecular weight heparin. But there is a caveat regarding edoxaban and rivaroxaban because they appear to be associated with a higher GI major bleeding compared to low molecular weight heparin in patients with luminal GI malignancy, while apixaban does not. We also have to remember that the DOAC trials, the randomized controlled trials, did not include patients, for example, with acute leukemia or patients with thrombocytopenia, and some of them did not include patients with brain tumor, patients with high risk of bleeding. Therefore, we have to go into real world data, and the RIETE-CAT study, which is part of the RIETE registry done by Manuel Monreal and colleagues, looked at the comparison of real world effectiveness and safety of enoxaparin versus tinzaparin or dalteparin in cancer patients with VTE at the registry. And this is because studies on tinzaparin, randomized controlled trials on tinzaparin and dalteparin, the CLOT and the CATCH study were published in 2003 and 2015. And now with this power of the registry, you can see that in this study, the RIETE-CAT, there was 3,500 patients treated with enoxaparin compared to 900 treated with tinzaparin or dalteparin. And actually, VT outcomes at 6 months after treatment initiation was similar regarding recurrence of VT, symptomatic DVT, and PE between enoxaparin and the other two low molecular weight heparins. There was also no difference in bleeding, major bleeding and non-major bleeding between the different low molecular weight heparins. And this was already shown by Sylvia before the Garfield VTE. And this is important because in real life, we still use a lot of low molecular weight heparin in patients with active cancer, at least in the beginning. You see 30 days, 3 months compared to DOACs, 6 months, and even at 12 months. Of course, this data may be evolving during this year's and upcoming years. Now, just to end with hematological malignancies, and this is from another Danish registry on 32,000 hematological cancer adult patients. You see that the risk, 10 years absolute risk for thromboembolic event or bleeding complication was 19%. And here you see the hazard ratio for MI, stroke, VT, and bleeding for these patients. And we know that patients with myeloproliferative disorders, especially polycythemia vera, are at high risk of arterial and venous thrombotic events, and that low-dose aspirin effectively reduced the rate of arterial and venous thrombosis in these patients. Until recently, the safety of dual antiplatelet and anticoagulant therapy was not established in polycythemia vera patients. And from this recent study by Jeff Zwicker, North American study of 2,500 patients, multi-center, non-interventional prospective observational study, they could conclude that combination of antiplatelet and anticoagulant agent increased the hemorrhagic risk substantially, 6-fold, with minimal further reduction of the thrombotic rate. There are special indications, for example, thromboprophylaxis at induction of pediatric patients with acute lymphoblastic leukemia. This prospective study of 950 pediatric patients compared unfractionated heparin, enoxaparin, and the antithrombin concentrate. And you see that enoxaparin and antithrombin performed well compared to unfractionated heparin. Major bleeding was very rare, and actually the author concluded that low molecular weight heparin was the preferred thromboprophylaxis because of ease of use and the cost. And another single center retrospective cohort study in adult patients now with acute lymphoblastic leukemia receiving L-asparaginase, which increased significantly the risk for thrombosis, venous thrombosis, especially cerebral vein thrombosis, which is a dreadful complication. You see that the low molecular weight heparin reduced the risk significantly with no documented major bleeding. What about DOACs in patients with hematological malignancies? These patients were very low number of these patients were actually involved in the DOAC study. In the Caravaggio study, there was 7% hematological patients, mostly myeloma and lymphoma. And you will see the comparison between the apixaban and dalteparin. And you see that there was a bit more in terms of percentage-wise of VT recurrence and clinically relevant non-major bleeding in the apixaban group. There was no major bleeding. So we need to get more data on this. And finally, risk assessment models, the goals would be, because of the heterogeneity in risk, this favors a targeted risk adaptive approach. We have to incorporate sensitive and practical biomarkers into thrombosis and bleeding risk models. And this is not easy because sometimes the risk for bleeding and the risk for thrombosis comes with the same risk factor, and we need to get an optimal predictive power. And the other point is to apply this in real time and repeat sequentially to optimize decision making. One step ahead, by the Vienna group, Prof presented this continuing measurement of the risk in patients with at risk for cancer-associated thrombosis. So my conclusion is that thrombosis and bleeding risk are high in cancer patients, that disease-specific risk assessment models may be helpful. Of course, we have the studies, the randomized controlled studies and the guidelines, but real-world data can contribute to clinical guidance. We have more experience using low molecular weight heparin than DOACs currently in cancer-associated thrombosis, and tailor-made management is recommended for each patient. And with that, I would like to thank you for your attention.
Many thanks, Benjamin, for this excellent clinically relevant talk. So there may be some questions from the audience. May I just ask you one question from my part? This relates to what you mentioned, the comparison of the different DOACs and lower bleeding with apixaban in the gastrointestinal tumor patients. What is your speculation why there may be a benefit for apixaban? Is this the twice daily dosing when compared to the once daily dosing of the other two? Or do you have an other explanation for that?
Well, I think this is an excellent question. I mean, your guess and suggestion, I think, is has a point, of course. We don't know. Of course, it's more when it's a luminal GI cancer. And if it's resected, then I think we are in a better shape.
Mm-hmm. Thank you. Yeah, I think we are approaching the next break. And if there are written questions, perhaps you could also then answer those questions in writing, Benjamin. Thank you so much again. It was a fantastic talk.